Hello and welcome to the API Healthcare Real Estate Investment Discussion. My name is Shehzad Jamal and I'm the partner at Knight Frank Healthcare Practice for the Middle East and Africa region. The format of this segment is that it is 10 minutes of a small presentation delivered by Dr. Gireesh, followed by a 40-minute discussion, panel discussion with learned stakeholders from the healthcare space. So I would like to leave the floor to Dr. Gireesh first, and he'll be presenting on healthcare real estate investment opportunities in Africa.
Thank you, Shehzad. Let me just share my screen here. Good afternoon, ladies and gentlemen, and thank you for joining today's session on healthcare real estate investment opportunities in Africa. My name is Dr. Gireesh Kumar, and I'm the sector lead for the healthcare advisory practice at Knight Frank Middle East. Before we go into the presentation, I'd like to take a minute to introduce Knight Frank. We are a global real estate consultancy firm with presence in over 60 territories. And in Africa alone, we have about 21 offices with presence in over 10 countries. The healthcare and education practice is fairly new, and we were established in 2018. Between then and now, we've advised clients for advisory and valuation projects in worth of X of about $1.1 billion. We've also done a few research projects, one key one being the Dubai Health Tourism Guide along with the Dubai Health Authority, and much recently the healthcare in Africa. In terms of the services offered, we provide feasibility studies, commercial due diligence, operator search and selection, and valuations. And as a team, we are a team of medical professionals, life sciences professionals, finance and real estate professionals. Moving into the agenda today, I'll be starting the presentation with COVID-19. And then we will go down into the healthcare real estate investment opportunities in Africa. So to start with, in terms of COVID-19, I will be presenting the general overview and a little bit about the preparedness itself. So globally, we've seen about 30.7 million cases until September 20th. And in terms of the growth rate, that reflects about 1% day-on-day growth rate at this point, which is lesser than about 1.7% back in June. In Africa alone, we've seen about 1.4 million confirmed cases, but the growth rate is much lower than the global average, so that's positive news. And in terms of the total volume in Africa, it's about 4.5% of the global cases. We also analyzed the preparedness of COVID in Africa, and if you look at one of the key indicators, is the screening test per 1,000 population. So in terms of screening tests, if you compare to countries like Russia and UK, where there were over 200 tests conducted per 1,000 population, nations in Africa had less than 10 or less than 10 tests per 1,000 population, barring South Africa. But we also need to understand that since Africa has had previous pandemic experience, they've had continuous awareness and surveillance in place, and successful contact tracing methods and public financing agreements to treat patients in private hospitals in case of demand surge. This is one of the key reasons why the numbers look contained in Africa at this point. In terms of the other indicators that we analyzed for COVID-19 was the ICU beds per 100,000 population. And the numbers or the density in African nations were far lower than countries such as Germany and USA. On the map in the right, we've analyzed the density across Africa for different nations. The ones marked in black have less than 1 bed per 100,000 population of ICU beds, but the ones in blue have more than 10. What this essentially indicates is a quantum of investment that is required in this segment and how the private sector can plug in this gap. In terms of opportunities in Africa, we'd like to actually discuss the demand drivers and why we believe there's potential in this market, the key challenges and opportunities, what the experts have to say, and why is healthcare development an attractive proposition for urban development. So the key demand drivers that we observed, one and the foremost being the changing demographics. Between 2019 to 2035, the population in Africa is expected to increase from about $1.3 billion to about 1.6 billion. Although the population is expected to remain young, with about 60% of the population in the age group of 30 and below. The age group above 40 to 59 and 60 plus is expected to increase at a faster pace, which essentially indicates that there's going to be growing demand for healthcare services, especially for chronic conditions, for rehabilitation, elderly care, as population in this particular age group have the propensity to use healthcare services more often than younger population. Although this doesn't mean that the regular services such as maternity and childcare will lose demand. If you see between 2019 and 2035, approximately 188 new births will happen, which essentially calls for more service in this space too. Another key demand driver we noticed was the urbanization. And at this point, 40% of the population live in urban settings, which is expected to grow to about 60% by 2050. And in actuals, this will be about 11 times the urban population of Europe. What this essentially indicates is that in the cities with higher density, the demand for healthcare services is expected to increase further. And also, the demand for lifestyle diseases or increased disease burden is expected to happen. Going forward, we expect that Africa will have an increase in lifestyle diseases. Traditionally, they've seen a lot of communicable diseases, but in recent times, as of 2019, we've seen about 2.8 million diabetic cases in Africa, which is expected to increase to about 4.2 million by about 2030. Key reason for this was the sedentary lifestyle and the consumption of processed food and fast food brought about by the increasing urbanization, increase in middle income population, which also indicates that there is increased affordability, so patients often travel abroad for treatment. To put this into perspective, Nigeria alone loses about $1 billion yearly on medical tourism. As I was speaking about middle income population, one of the key demand drivers which you see is that between 2019 to 2050, the population of middle income segment will increase from about 355 million to about 1 billion, which is approximately 50% of the population in 2050. What this creates is a pool or 50% of the population with higher spending power, which dictates additional demand for healthcare services and increased quality and infrastructure. But in terms of infrastructure itself, Africa has had deficiency long-standing, and we wanted to analyze the actual gap. We compared it to the global average of 2.7 beds per thousand population, which actually considers the developed as well as underdeveloped countries. So in Nigeria itself, we see a demand for about 386,000 beds at present, based on the global average, and dropping down to about 70,000 in Kenya. In terms of investment itself, this dictates about 82 billion in Nigeria and about 11 billion in Kenya. To put this into a better perspective, just to maintain the ratio of beds which are actually there in these countries at this point, they will require about $1.9 billion from last year to this year to continue maintaining the bed density. Another key investment sector that we've seen was the technology advancement. And in recent times, we've seen big data, telemedicine, teleradiology gain a lot of popularity. And in Africa itself, this has been the case with Africa. Sub-Saharan Africa has been considered as a new market for telehealth and digital health. On the other hand, this will also help in providing healthcare to remote locations. In urban settings, this will also probably reduce the regular size of hospitals as more and more services become remote. But this is definitely going to be an interesting sector for investment going forward. We also mapped the key challenges in this sector and tried to identify opportunities out of it. One of the key challenges that we noticed was the healthcare workforce. Retention has been key. There's been dependency on expatriate workforce, and the remuneration packages have been far lower than the rest of the region. This also indicates that there is a lack of quality, and this is a continuous circle. But what this brings about is the opportunity to, one, have healthcare additional facilities in center of excellences, multidisciplinary hospitals, medical wellness centers. But in addition, it also creates a demand to invest in healthcare education facilities, providing medical, nursing, and allied health professional courses to create a domestic pool of healthcare workforce. Another key challenge that we noticed was the indication that this sector is an emerging sector for attracting capital. But this has not been the case. For example, the IFC has recently set up a $115 million fund to invest in the sector and activate it. And some of the countries such as South Africa and Tunisia have seen dearth of, as in a large amount of medical tourism patients. South Africa alone has seen about 1 million medical tourism patients annually, and Tunisia has seen about 500,000. So what this indicates is there is definite demand for medical tourism here, and infrastructure is in place, but with additional infrastructure and quality, be able to gain more traction in the segment. definitely calls for more investment in the healthcare. And additionally, it provides first mover advantage and long-term growth potential. We also spoke to the experts. We spoke to some of the investment funds. We spoke to some of the operators. We spoke to some of the medical tourism operators to understand if healthcare REITs is a viable option in Africa. We asked them three key questions. One was, is this a viable option? What is the investment criteria? And why is this an attractive investment? So the response we got was, yes, this is definitely a potential opportunity. It's a viable investment sector with low risk and long-term returns. And the preferred investment criteria was established assets, the established brands with presence in the market, acquire them. Or the second option was to move into a new facility, but with the established brand. Why was this investment considered attractive? It's because, one, it's always been considered a defensible asset. It provides triple net lease options, and the demand, which is sustainable. Going forward, the population is expected to increase, the middle income segment is expected to increase. So there is continuous demand for healthcare. And along with that, with the restrictions brought about by COVID, there's going to be more intrinsic demand for healthcare service in Africa. In terms of investment activity, Nigerian Women's Hospital. And in terms of financing initiatives, we have already discussed the IFC fund created for investment in the health sector. We also wanted to understand why healthcare was an attractive proposition, especially for an urban development. So in terms of real estate, in a typical urban development, what we've seen is residential, retail, and F&B developments, which essentially creates a certain number of footfall and spending in that development. But in the same development, when you introduced a healthcare development, what it essentially creates additional 600 jobs and about 1,400 visits per day, which basically activates the rest of the developments in that master plan. And also in terms of the additional 600 jobs that create and the families that come along, it also activates the residential demand in that development itself or in the surrounding areas. That's why I believe healthcare is a very important part of any future master development, because in terms of creating demand, it actually activates everything else in the sector and becomes an anchor tenant. With this, I end my presentation. Thank you so much, and I'll hand it back to Shehzad.
Well, thank you very much, Dr. Gireesh, for this informative presentation and also finishing spot on time. Joining me for the next segment are recognized sector professionals from whom we should learn a lot in the next 40 minutes. I have with me Derek Nikera, Lead Project Manager from Turner & Townsend. I've got Olaf Schmidt, Investment Manager of the IFC, responsible for the African region, and also Sheila Chipkonga, Lead Consultant for Credence Healthcare Limited in Kenya. Before I start this discussion, allow me to summarize or frame a few key points that I've learned from Dr. Gireesh's insightful presentation to set the tone for our discussion going forward. So as I can see that the population growth in Africa is faster than the rest of the world, and the population over the age of 60 is going to increase by about 1.8 times by 2035. The other interesting points that I learned was that urbanization is going to touch about 60% with the urban size greater than 11 times that of Europe, increase in lifestyle diseases, and there's a visible infrastructure gap which presents opportunities for all. And there have been various initiatives that have taken place over the last few years. That brings me to you, Olaf. From what I understand, could you put your mics and cameras on, please?
Here I am.
Fantastic, fantastic. So like I was saying, it brings us a lot of opportunities for this sector. And I understand that IFC's invested huge sums of money with the private sector in East African region, right? And there has been some investment within the healthcare space. Would you be able to comment on this and also provide like a comparison of what was done last year versus this year, and also the subsectors within the healthcare space? that you invested in.
Thank you so much. Thank you so much, Shehzad, and welcome to all the listeners to this panel session. Very excited to be part of it. Thank you for having me with you. And perhaps very quickly, I mean, just laying a bit the ground. IFC is the private sector arm of the World Bank Group. And so we really try to foster private sector development in emerging markets. And I mean, as I see, just to give you kind of the bigger picture, we invest yearly roughly $22 billion into emerging markets. So we are a very sizable player when it comes to private sector engagement. And actually, I'm looking at, I mean, just to frame that too, here in Sub-Saharan Africa after the services and manufacturing sectors. The investments in these and services entails for us, which is quite relevant for this session, on the one side, health and education, and on the other side, real estate and a few other subsectors. But so it's really at the crossroad, and I will later perhaps share a few thoughts on you know, how we can combine them even more. So, but giving, you know, perhaps a bit more now the nuanced background here in Africa, we in Africa have invested roughly 1.5 billion in these sectors. And they are strategically important. As you all know, the Human Development Index is very low in many countries. And as we have also heard from the previous speaker, I mean, the quality and accessibility and affordability remain all critical concerns on the continent when it comes to healthcare provision. And that has been recently, I mean, even become more obvious with the COVID pandemic. In that regard, I mean, we, for instance, as IFC, have reacted very quickly and availed $8 billion in the pure COVID context to existing clients in the initial phase. It will be rolled out also to other platforms, including a global health platform, but to really sustain and support them during this crisis, which has affected many companies, given lockdowns and just less foot traffic in labs, clinics, etc. So that was one very immediate response from our side. In terms of what we traditionally do, and I will lay perhaps that ground first, and then perhaps in the next round I will talk a bit more about the merging between real estate and healthcare in the REIT space, for instance. But we traditionally look at healthcare networks, be it clinics, hospitals, or more specialized networks in oncology or cardiology. I think we are one of the probably biggest investors in this space in Africa, given our mission and vocation, trying to move the needle and bringing more private sector solutions to this space. And I mean, particularly the lab service, for instance, in the COVID context, very interesting and clearly something which would benefit from being expanded across the continent. And again, from our standpoint of view, also for lower income populations, I mean, how can you make sure that there is accessibility? So perhaps one example just to visualize, we invested recently in this very last few months, was the last closing, $80 million in the hospital holding investment platform. That is basically a platform of hospitals in East Africa. It was done over subsequent tranches, and we attracted multiple outside private investors alongside us. We did that together with a fund called IFA, based out of Europe, but again, with the idea to look for more scalable solutions in this space. So we take, the idea is to create a platform, bring on often a family-owned hospitals into the platform, and then help them, get to the next level and become, a scaled response with a more standardized quality approach, and also looking at affordability. So I think that's, gives you just a sense what we often do. We are working with the market leaders, be it in Kenya, Uganda. I mean, that was in Uganda, Kenya, but also Nigeria, Mauritius, South Africa. So we are really active across the continent. And I think that whole consolidation and looking for scalability will be important as we look for more sustained and more programmatic responses in the healthcare space. Later, I mean, I will give back now to you, Shehzad. We can perhaps look at how we can combine this with the real estate side, which represents a very significant portion of the investment cost of when you build a hospital, often up to 70%, and how we can perhaps merge these two. But for now, I pause and back to you.
These were great insights. Thank you so much. And I mean, I was taking notes that, I mean, you're investing in creating networks and in the private space is talking about scalability. And Sheila, I would like to ask you that with all this means improved infrastructure, it means that there's more accessibility and penetration. But on the flip side, we also need to understand the payer's ability. Would you like to share some light on the universal healthcare insurance system across the region? Because these are the people who's going to pay and avail these services.
Absolutely. Thank you so much for this opportunity. Thank you all for sharing that wonderful insight on the investment that's happening in Africa. With regards to universal healthcare access, Kenya has taken a lead in that, and we are currently looking at having universal access as something that all Kenyans can have by 2022. But what we're starting with is reducing the out-of-pocket costs to Kenyans, which currently sits at 26%. So we're hoping to reduce that by 2022 down to 12%. So almost a 14% reduction out-of-pocket costs for Kenyans. So with regards to payer capacity, it varies. We have a discrepancy still because of our poverty index. Our GDP is still coming up. Kenya has just been declared a low middle income country. So there's a lot of adjustment that's happening on the sector. And we're looking at it more as a process and, also looking at the political buy-in and goodwill from our leaders to effectively make this a reality for Kenyans. So with regards to the access to healthcare, that's still a bit of a challenge. We do have a lot of facilities in Kenya. At last count, we had about almost 11,500 facilities, health facilities available in Kenya. But most of this do not have the capacity to offer the essential services or other specialized services that most Kenyans require. So about 80% of these health facilities can offer primary healthcare services, but for the specialized care, very few, and most of those are found in the urban and peri-urban setting. So a lot of our population that is in the marginal rural areas, they still have to go over 5 kilometers to access healthcare, access good infrastructural healthcare. So that's a gap that we still need to meet. And I know there have been a lot of willing investors who want to come in, and this is the time, I'd honestly say this is the time to come and invest in East Africa. We have the potential, we have the zeal for it, but we need the partners to come in and, say, we would like to work on this with you and get that done. With regards again to the payer capacity, let me just delve a bit into it so that you can understand the economics behind it. 1 out of 5 Kenyans will not be able to afford healthcare. 1 out of 5. We currently have a population of about 48 million Kenyans. 4 out of 10 of those who can afford would have to sell their belongings to pay for healthcare. So this is something that is still an issue for our government. It's something that even for us in the private sector, we're trying to find cost-sharing models that can work in line with the National Health Insurance Fund, which is the key player in the universal access healthcare model. There's been a wonderful pilot project that has been done in Makueni County, one of our counties within eastern block of Kenya. They took a sample of 162,000 households, and they just told, they ran a mathematical model. And out of that, each household had to raise 500 Kenyan shillings. And that has seen such a transformation in that county, because they've seen 70% of the population access free healthcare services, comprehensive free healthcare services, because of being able to raise 500 Kenya shillings. I think that, for us, as an example, and if it can be rolled out to other countries, I think within East Africa, it would be fantastic. 4 other pilot sites have been selected in Kenya, so that is currently being rolled out. We will get the statistics and share with you again. But it is something that is scalable. It is something that can be done. And if we partner and just build the capacity and make more advocacy programs around it, I think we'd have a better level field for a lot of East Africans as well to access healthcare. And I believe the same thing is being done in Rwanda, the same thing is being done in Uganda. Tanzania have their own system. So it's something that is now becoming a reality for us in this block, in the East African block. So I think it's a wonderful idea, and I'm really excited. Olaf, the investment that you're doing through IFC, it's such a blessing to us. So please just let's have more discussions. And I like the way that you're taking the family-owned facilities, because it reduces the red tape when you have to now bring up the scalability of the facilities. There's less bureaucracy in it. So that's a fantastic way to approach it.
Well, thank you so much. These were like great insights from you, Sheila, and I'm glad that things are tying together with the IFC investment. And what we're seeing is that like you mentioned, that there'll be universal access. I mean, the cost of availing services would reduce by 2022, and there's a series of investment going on. So if I come to you, Darren, and I ask, how do you see the investment activity change within the healthcare sector? Are you seeing that there's more investment within the secondary cities, or more because there's urbanization and there's more investment activity and construction activity for healthcare in the primary cities? Would you like to shed some light on that, please? You'll have to unmute your microphone.
Sorry, I was following instructions. Thank you very much. Thank you very much again for the opportunity. Certainly welcome the opinions and input from my co-panelists, Olaf and Sheila. I certainly learned a lot from what you presented today. I also like to thank Knight Frank, I think, who gave some wonderful insights as well. So the question around construction activity in the healthcare sector, we have to connect it, as you quite rightly say, to the urbanization.
Yes.
What we have in terms of trends and pace of urbanization, which, as we know, will be faster on average than anywhere else around the world. Africa does have quite a big gap in trying to catch up with the rest of the world from an urbanization perspective. I would like to connect what we are seeing in terms of construction activity with some of what Sheila said, and certainly some of what Olaf said. We are seeing in our own organization, Turner and Townsend, who are the biggest construction consultancy in East Africa. We're seeing investments and execution of projects of multiple profiles. So we are seeing what you've got in terms of upgrade of the traditional referral hospitals. We're seeing that in Kenya at the Kenyatta Hospital. We're also seeing that in Uganda with the Mulago Hospital. These are hospitals that have existed for 50 years and more. So we're seeing actually what's happening is that they are being upgraded and just being brought into what a 21st century hospital should be, in terms of the equipment, in terms of the facilities, in terms of the and of course aligning with some of what today's threats are, the need for isolation, which certainly COVID has taught us. Some of these hospitals didn't have the facilities to actually isolate floors. So you find that the upgrade of these hospitals is happening at a time when there is a threat that certainly the whole world has had to face head on. So, in some ways that has helped these hospitals. We're also seeing investment in you know, facilities that are in the rural areas. So what you're finding is that some of the investments that, and certainly projects that we've worked in, are breaking the myth and breaking the mold as to what and where hospitals should be built. You know, we're seeing certainly healthcare facilities being put up in rural areas. I mean, I've worked on a project whereby we had to first start with building a road to get to the site of the hospital, you know, and this is allowing people that have been living in traditional rural areas to get access to that healthcare, which I think is what Sheila was talking about in terms of the universal access. We cannot afford to wait for the pace of urbanization to, you know, to be complete before the healthcare is provided to these, you know, to these individuals. The Millennium Development Goals, I think, speak to issues such as child mortality rates, maternity related deaths, and needing to bring those down because they were just abnormally high in the rural areas in Africa. In terms of strong activity, we're seeing, like I said, a lot of investment in private hospitals. The governments are certainly playing their part because I think, you know, healthcare-related projects are quite unique in the sense that just by their scale and complexity, and obviously the close relationship required between these facilities and the Ministry of Health, it's important that the governments are a close partner. And we're seeing that, I think, coming to the forefront in places like Kenya, which Sheila spoke to in terms of the Big Four agenda. We're seeing that in Uganda, where massive projects like the Finasi International Specialist Hospital of Uganda, which is over 250 or close to $300 million investment happening. And this, I think, is all trying to close that gap, like I said. But the good thing about it is that it's closing a gap at a time where Africa can actually leapfrog the rest of the world in terms of delivering first-class technology today. So you have companies like Siemens, like General Electric, that are able to provide sort of first-class facilities, and we are kind of figuring out how to do it in ways that we are leapfrogging and doing it in the 21st century. So that is part of the benefit. Africa also provides almost a blank slate. You know, you have an opportunity here to test concepts. Sheila spoke about a pilot project. You know, so the landscape in Africa allows you to kind of, you know, test concepts that you can then demonstrate to your investors, all up and all the other partners that people like Knight Frank will be speaking to, whereby, you know, you've got something like in Rwanda specifically, a drone delivery of medical supplies. I mean, who would have thought that was going to happen 10 years ago, you know, and now that could now be proven as being successful for places like Africa, where we will not have the roads and we will not have, you know, the means of getting these facilities or these supplies to the population. The other thing I'd also like to talk about is the alignment of some of these healthcare projects with sustainability. You know, as much as we're talking about urbanization, it is being coupled with what we need to keep at the forefront, which is sustainable development. You know, there's no point in us building facilities, building communities that will not be sustainable or healthy for people in the next 20 years. So I think you actually have a very interesting opportunity for investors to actually align the delivery of healthcare with sustainable development. So I think Africa presents that exciting opportunity, which you know, which we are certainly very excited to be able to participate in. The last thing I'd like to say is, while we talk about the construction activity in the healthcare sector, you know, it's not just about the facilities, being the hospitals and the clinics. You know, we are also seeing investment in things like the medical supply chain. So we're seeing warehousing, we're seeing manufacturing companies, we're seeing a lot of this happening the two go in tandem. You know, you can't expect to build all these hospitals without being able to supply them with the equipment and supplies. And one thing that COVID has taught us is we cannot rely on necessarily bringing all of this in, you know, because we've certainly faced challenges, I think, in trying to get some of these supplies and equipment in time. So I think there's also that robustness that's being built within the value chain and the supply chain of the entire healthcare space. So it is exciting, I think, to be involved in some of the warehousing projects, the logistics projects, and all coupled with obviously the primary investment, which is in the medical facilities themselves. Thank you.
This is really interesting. This is really interesting because I think we're all moving in the right direction. And as far as investments, you're saying in upgrade, you know, when the private sector upgrading, the government sector upgrading, then we're talking about, you know, I mean, companies like GE and Siemens also, you know, putting first class infrastructure in there. there's also a lot of financing that is also going on. And of course, the last mile delivery, you're talking about that, you're talking about stuff that is, like, for example, the complete value chain. That means we've got the infrastructure in the making. I mean, Sheila, I would like to ask you, with all that in place, do you think there is, how will that affect the medical tourism industry, especially the outbound medical tourism industry? Because I understand that this is quite huge for Africa, and a lot of people actually do travel abroad. I mean, there's certain people who will be traveling abroad habitually, I mean, because they can just afford it, and certain people are doing it because of circumstances. You think you can shed some light on this?
Absolutely. Thank you, Derek, for that very insightful conversation. Just if I could just dial back onto him first. There's something he mentioned on the value chain that I think is so pertinent. And you know, in Africa, we get a lot of equipment that comes in. And I feel this is the right time to harmonize the upscale of the infrastructure building with the equipment that we have, because we do receive quite a huge chunk of equipment that comes in, but because of lack of the infrastructure, a lot of this equipment goes into obsolescence. You know, it just end up being junk. So I think this is the right time to marry these two concepts and just have a more robust value chain, as you said, for our healthcare system. I'm excited about that.
Can I stop you there for 1 second? I mean, this is a very interesting point that you raised, and I'm wondering, Olaf, do you have some sort of protocols to ensure that what Sheila just said, that about good equipment getting obsolete, doesn't happen again? Because then it just defeats the purpose of all the investment.
Yeah, no, absolutely. And I took quite a few notes, actually, as Derek and Sheila went along. I mean, there's so many sub-themes you could explore, but I will just dial in on the equipment finance, because that is critical. I mean, what Sheila says, right? I mean, there has been a lot of focus on bringing equipment, but then if the lifespan and the utilization is really not there, you completely miss the point. So for us, this is very, very important. I think it goes also hand in hand with another aspect which we haven't touched on, this the whole education part, right? How do you upskill basically hospital, you know, kind of employees to operate? So in a nutshell, just to say something, I mean, we have worked very closely in rolling out multiple equipment finance facilities. And I think the key to success is that you team it up with technical assistance, that you really avail whoever is then the operator of these with the right knowledge to A, purchase the right equipment for the need of that clinic or that hospital, and help think through on the financial viability, right? Because if you bring an MRI into a hospital, you want to really make sure that you understand these cash flows and, you know, provide there basically the assistance, the technical assistance to help that operator to think that through. And then thirdly, work very closely with the operators and the manufacturers to ensure, and after, you know, kind of during the installation, the right technical support, and including afterwards, right, for the lifespan of the equipment. And I think there, what is interesting is to collaborate really with a variety of OEMs, right, so equipment providers, and offer that more systematically into the market. We have started to do that in East Africa and in West Africa, collaborating with banks, because you then basically, again, can reach more, you know, smaller hospitals that are in need for that, and ensure that they get the right equipment and the right training and guidance around it, so that we avoid what Sheila is talking to, which is one of the real challenges in this context. Thanks.
Understood. Sheila, I'd like to get back to you quickly, so that we can circle back right to the medical tourism opportunity that we have. And I think I would like to also, when you discuss this, I think there's probably one more point that I want you to consider, is the effect of COVID on this medical tourism angle as well.
Okay.
Brilliant. Okay, over to you.
All right. Thank you so much. So with regards to medical travel, Kenya is both inbound and outbound. We do both domestic and international travel. So we have in the past 6-7 years, been receiving a lot of patients coming in from the region for treatment in Kenya. Most of those cases come in from Ethiopia. We have a lot of IVF patients who come to Kenya for that. We have a lot of orthopedic patients coming in from Burundi, from the Congo. We have some coming in from the South Sudan, coming into Kenya for orthopedic treatment. And then we have, in the last 2 or 3 years, have had patients just coming in purely for diagnostic cases out of Burundi. And last we had a case just because they couldn't have an MRI in their country. So they came all the way to Nairobi for an MRI. So there's been it's such a robust opportunity for us to have inbound medical tourism coming into Kenya. But on the converse, we have a lot of Kenyans leaving to go out and seek medical treatment, particularly in the Indian subcontinent. And the reason for that is we're looking for the specialities that are not available in Kenya. Or if they're there, they're not able to meet the demand of the market. So some of these conditions are renal kidney transplant cases, where a lot of Kenyans we have seen an increase in renal diseases in Kenya as a result of lifestyle, sedentary lifestyle as well. Liver transplantation is something that is also is becoming an increasing need now, some cases because of hepatitis and that type of thing, and pediatric cardiology cases. So those are some of the, I'd say, super specialities that we always have patients traveling out to the Indian subcontinent. Sometimes we have patients going to South Africa, particularly in Cape Town, to go for neurology cases. There's a time in Kenya we only had about 11 neurologists, specialists for the entire country. So, but we've seen an increase in us getting proper trained medical staff, being trained, coming up through the ranks, being able to handle most of these cases locally. The reason why we have this sort of exporting of patients is purely because of one, quality, and two, cost. The reason I talk about quality is we do have quite a number of healthcare facilities, but the infrastructure cannot support the surgeries that are needed. So our operating theaters are what needs a lot of infrastructural investment. Yeah, we have quite good enough inpatient facilities, but our operating theaters and our ICUs are what we need infrastructural capacity building in terms of the actual building, in terms of the equipment, in terms of the skill transfer, in terms of like what all of us sharing. When we buy the equipment, we need the technicians to be able to be on ground, to be able to service this equipment, to avoid the breaking down and the whole value chain being obsolete in the process. So with regards to how COVID has affected us, it's been quite significant because a huge population of Kenyans have not been able to access healthcare because of the fear that has come in with this COVID. Sorry, there's an ambulance passing by. My office is right next to a hospital, so that's why there's all this noise. The COVID pandemic has really caused an interruption in the system. It has caused an interruption in medical value travel. And why is this? Borders closed. Patients could not leave the country to go and access the healthcare that they deserve and need. While at the same time, the healthcare that we could access here locally was also a bit challenged because of the fear of patients going to hospital and contracting diseases. So we were not able to receive patients in Kenya, and we're not able to export patients out of the country. So there's been a huge impact.
May I ask, with all this, with this, and also we're talking about using drones and everything, was there an element of utilization of telehealth that came into?
Yes. So we as Kenya, we are really embracing telemedicine right now. There's been a huge discussion about it. We have several applications that are currently running where patients are able to interface with their doctors through their insurance companies, doctors who use certain apps like Tibu Health, there's Ask a Doc, there's Sasa Doc. So there's so many applications that have come up now where patients are able to interact with their doctors without having to go to the clinic. But the hiccup is not many Kenyans also have smartphones. Yeah. So luckily, Safaricom, our biggest mobile services provider, has come up with a plan whereby every Kenyan can now pay 20 shillings, I think, every month or every day, and they'll be able to access a smartphone. So with that, patients will be able to get in touch with their doctors and not have to travel all the way to the clinic for conditions that can be treated without having to go all the way. They can be given e-prescriptions, they fill it out at their local pharmacies, pick their prescriptions.
Is it all insurance covered as well? Is it being covered by insurance?
Not all. Majority are insurance-based. So there's that discussion. We have a Ministry of Health program called mHealth. So mHealth is the one that runs everything that is electronic medicine. And all these platforms, Sasa Doc, Tibu Health, they all run on the mHealth platform, which is a merger between our Ministry of Health and our Ministry of ICT. So so that is something that's really taking on. It's really peaking. We're currently doing telemedicine for our patients who are seeking to go for treatment abroad. So we're preparing them now through telemedicine before they go. We're having patients who we do intra-bound medical tourism. So for example, I'm in Nairobi, the doctor is in Eldoret.
Correct.
So we facilitate that. They have their initial appointment.
Screening and everything.
We share medical records to the system, and it's working well. So there is still a huge gap that we can fill with that, probably, and I dare say for teleradiology. That is something we need to look at.
I've read about this, but I would like to stop you there for a second. I'm conscious of time. And I want to ask Ola one thing that, for the benefit of the audience and the benefit of everybody here, can you cite an example of a successful healthcare investment proposition, either in the public or private sector, that has been financed through the IFC, and what was the value proposition that they had to offer, so that so that others in this others who are listening to us can also benefit and present a case that can be acceptable to your organization.
Yeah, thank you so much, Shehzad. And I mean, given that we are within the context of a property conference, I really now want to zoom in to, I think, the core of how can we merge more the health aspect and the real estate aspect. And the example I will give is a recent investment we did here in South Africa with a leading property developer, Growth Point. What is very interesting, I think, here is that traditionally they are more on the commercial real estate side, as I'm sure that many of the audience participants probably are quite a bit on this API conferences on the commercial real estate side. And yet here, basically, the strategic choice that Growth Point has taken a few years back is to say we want to start building a new asset class in the healthcare space. And I think the idea to us, I see extremely appealing, because you start to separate the property development and kind of skills that is very, widely built around the continent, I would say, and merge it with the need on the infrastructure building side in the healthcare space. So while you might find, as in this case, often very strong operators, I mean, kind of be it family-led or doctor-led, let's say groups that know how to run a hospital, given how important the investment size is to build these hospitals, that's a huge entry to barrier, right? And I think that's where this opportunity lies, to say we separate the two, and we avail basically the walls in which one can run a hospital to interesting operators. And I think that has many advantages, but I mean, I try to simplify that visually and kind of say that is very interesting as you try to build up competition in this space, as you try to reach scale, so that perhaps an operator who would be able to have one hospital in one country now with such an approach might be able to envisage having a whole chain of hospitals. And you know, in South Africa, of course, there the REIT market is very developed, and basically this is the end game, that you then eventually, you know, can list this kind of entities when you have the significant scale, etc. I think what now will be and many of you will wonder, why is it not done in many other African countries? And I very much like Derek's point about, you know, let's think about this as a clean slate opportunity. So I think, you know, moving those concepts to other markets would be very interesting as we look for, you know, really improving the healthcare infrastructure, which is so much needed in many countries, and bringing the property expertise that is there and merge it with the healthcare's operation side. And if you do that, I think that there is an opportunity to bring it to other countries. Of course, it will require that you team up with regulators. You need to have the right you know, legislation in place. And you need, you know, to have the investors understanding the product. So there's a lot of, let's say, education again, in a way that you need to do. Yeah. But, you know, when you look, even in Kenya, Uganda, Ghana, pension funds are there, and they are looking for investment opportunities. And actually, I think the COVID pandemic has even exacerbated the need to not rely only on commercial property, which has been hit quite hard, and look at what are alternative investment asset classes. And the healthcare space and equally the education space are very, very interesting, because you will need these services to go through, right? I mean, they might have a little bit different shape, etc. But it's very different from a shopping mall, which of course has been very much affected during this crisis. So I think we are at a very interesting point to relook at this asset class of healthcare and merge it with good property, you know, balance sheets and knowledge.
Yeah, these are necessity-based services, so they have to have a long-term, steady demand. Derek, I want to close with you really quickly, and very short, precise answer I need from you. Is the healthcare, the construction that you're seeing in the healthcare space in Africa, investment grade for companies like IFC or REIT funds or international funds to consider investing in this? Because I feel the biggest issue is for these funds to consider something investment grade. Are we seeing this happening now?
Thank you very much. And I think, you know, Olaf had started to speak to that at the end of his presentation in terms of, you know, how the profile of investments is certainly needing to shift. Because I think what we have at the moment is basically that healthcare-related investments and facilities would probably, in this case, and looking at what's happened over the last 6 months, provide a more safe investment in terms of the potential impacts. Like you said, this is a need.
Correct, I understand. But are we looking at the infrastructure improving so that it's investment grade? That's the question. Is the quality of construction?
Yeah, I would have absolutely simple answer, yes. And the alternative opinion on that is that, you know, there's certainly been proof that we shouldn't wait and not have one come before the other. You know, I think there's got to be new ways of thinking about how healthcare sectors and healthcare facilities can be provided. You know, it's clean slate, it's new thinking. We've got the technology, we've certainly got the ability, you know, to combine some of the best of what exists in the world today with what certainly places like Africa need. So as far as the infrastructure, as far as the personnel, the intel and the capacity, it is all there, it is ready, and like all I've said, I think it's just about putting all these pieces together.
Fantastic. I think, thank you very much. At this high note, I think we should put a close to this event, or sorry, this session of ours. Thank you very much for your time, everybody. And I hope for the audience, I hope you've enjoyed this discussion. Thank you very much. Goodbye.
Thank you. Bye-bye.
Thank you so much. Cheers.